Hey, good evening, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar, part one of our Geriatric Miniseries. We are thrilled to have Shireen Farzadeh and John Noviasky as our guests who will present today. Shireen Farzadeh earned her PharmD at St. John's University College of Pharmacy and Health Sciences in Queens, New York. She completed her PGY1 pharmacy residency at Northwell Health, North Shore University Hospital in Manhasset, New York, and her PGY2 geriatric pharmacy residency at SUNY Upstate University Hospital in Syracuse, New York. Currently, she is the Transitions of Care Clinical Pharmacy Specialist at the New York City Health and Hospitals Kings County Hospital here in Brooklyn. And she's passionate about medication management in older adults and bridging the gap in health inequities between the underserved patient populations and access to care. Her practice involves rounding with an interdisciplinary team of internal medicine and telemetry unit and conducting discharge medication reviews and counseling for patients with an increased readmission risk. Her recent accomplishments include receiving the 2020 ACCP Geriatrics PRN Resident Travel Award and first place poster on her PGY2 project, Impact of a Clinical Pharmacist Telehealth Service in a Geriatric Assessment Clinic at the 2021 ASCP annual meeting. John Noviasky is a board certified pharmacist and has been the PGY2 Geriatric Pharmacy Residency Program Coordinator at Upstate Medical University since 2019. As a geriatric clinical pharmacy specialist at Upstate Community Hospital, John has worked closely with PGY2 Geriatric Pharmacy Residency Program Director to develop the residency program, as well as the geriatric related programs in the emergency department, the transitional care unit, and the acute care of the elderly team. John is actively involved in research with multiple quality improvement projects that focus on the older patient. These projects address dosing of potent medications in the emergency department, avoidance of overnight medication administration, improving administration of medications for Parkinson's disease in the emergency department, and deprescribing. Now, before we get started, I'd like to share a few quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in the resolution. Now, for those who have questions that you would like to direct to the speaker, please use the question box or the chat option. And next, the CE code for this program will be provided at the end of the program. So with that, I would like to go back to our first speaker, Shireen Farzadeh.
Hi, everyone. Thank you for the introduction. Today, I will be presenting on following short of medications, the role of pharmacists in preventing falls among older adults. I have nothing to disclose. By the end of this presentation, you will all be able to describe the prevalence and significance of falls in older adults, identify medication, disease, and environmental related risk factors for falls in older adults, recommend deprescribing, fall risk increasing medications, and explaining their mechanism for causing falls, as well as educating patients on non-pharmacologic fall prevention measures. Before we go into the discussion on medications, I will first define a fall. According to the American Geriatric Society, falls that we will be discussing are the unexpected event at which the individual comes to rest on ground or lower level with no known loss of consciousness. This excludes major intrinsic events such as seizures, stroke, syncope, which should all be evaluated and managed. You may have also heard the term mechanical fall. It is important that we avoid this term as it inaccurately implies that a benign etiology for an older person's fall exists. Why is it so important that we play a role in fall prevention? It is no surprise that falls are the leading cause of injury among older adults and the fifth leading cause of death. What adds to the danger of falls is that only half of older adults can get up afterwards. Falls contribute to 3 million emergency department visits per year. While I was in the ED, I saw at least 5 to 10 patients coming in with a fall per day. Many of them are hospitalized with more than 950,000 per year, and unfortunately, falls lead to 32,000 deaths per year. Of course, to demonstrate our value to the healthcare system, the cost of fall-related injuries in older adults is $50 billion per year. From a non-medication related perspective, some intrinsic factors are chronic illnesses, including orthostatic hypotension, arrhythmias, Parkinson's disease, rheumatic disease, urinary incontinence, and depression and anxiety, including the fear for falling. Moving along to more intrinsic risk factors that can also contribute to falls include poor balance, use of a walking cane. It's important that we can check if patients are using them appropriately, general weakness and pain, acute illnesses, and hearing impairment, visual impairment, cataracts. This is where cataract surgeries can help, as well as cognitive impairment, as reflexes can slow down. As a patient ages, their absorption, distribution, metabolism, and excretion changes, which can often lead to higher and even toxic concentrations. Starting with absorption, older adults have decreased motility, increased pH, which can also decrease absorption of medications needing acidic environments such as calcium carbonate, and decreased blood perfusion. For distribution, older adults have more body fat and less water. This can therefore increase the half-life of lipid-soluble drugs such as tricyclic antidepressants and benzodiazepines, and hydrophilic drugs such as digoxin. The majority of medications are metabolized in the liver and excreted by the kidneys, which with declined function in either, the half-life for the medications can substantially increase. Switching gears to environmental risk factors, most falls occur inside their very own homes. This is why we need to ask patients how they fell and remove potential culprits, such as poor lighting, where we can suggest a nightlight, as well as no safety equipment for the bathtub, where we can work with the team to help them get safety handrails, loose carpets and extension cords, as well as slippery footwear, where we can suggest wearing non-skid socks. Moving along to fall risk screening assessments, there are many that you can find, but I will highlight this one specifically. For this patient case, we'll be using the Fall Risk Reduction Toolkit and checking off boxes we can from a pharmacy-related perspective. This patient is an 80-year-old female with back pain, 6 out of 10, depression, hypertension with dizziness, insomnia, history of falls with 3 in 2021 and a hip fracture, as well as obesity and chronic kidney disease. She lives alone, she is ambulatory with a cane, and drinks 1 glass of wine per day. She's presented to the emergency department with a fall and confusion and has medications in original vials in her purse with fill histories from 2020, which were diphenhydramine, doxazosin, ibuprofen, oxycodone, paroxetine, vitamin C, and zolpidem. This Falls Reduction Toolkit is a collaboration between the American Society of Consultant Pharmacists, the National Council of Aging, and the Centers for Disease Control, Stopping Elderly Accidents, Deaths, and Injuries, otherwise known as STEADY. It contains a checklist broken into sections that can be filled by various members of the healthcare team. For instance, general patient factors, transition status, living arrangements, and substance use. For our patient, she is age over 65, she lives alone, and drinks 1 wine per day. For vital signs and ambulation status, our patient stated that she is dizzy and lightheaded with standing, has back pain 6 out of 10, and walks with a cane. The gait, strength, and balance test can be filled by the physical therapist or providers, which consists of the timed up and go test, 30-second chair stand test, as well as a 4-stage balance test and observed gait problems or difficulty standing. But we can fill our patient's fall history, which she did have 3 falls in the past year with injury, depression, impaired renal function, pain, and obesity. And last but not least, medications. For medication self-management, we should ask patients if they manage their own medications, how they organize them. Are they taking their medications from pill bottles, or are they adherent? We can assess their fill history. For our patients, her medications were disorganized. There were evidence of adherence issues as she had the original files with fill histories from 2020. Medication assessment also consists of identifying the number of medications they have to take, recent changes, and this is where we conduct a thorough drug regimen review where we can determine if patients have any medications that have a suboptimal dose, interactions, intolerances or allergies, dose too high, lacking medication therapy for all medication requiring indications, unnecessary medications, safer evidence-based therapy available, or difficulty administrating any of them. For our patient, she has more than 5 medications has unnecessary medications as well as safer evidence-based therapy available. We'll go into the specific medications contributing to falls in the presentation, but I do want to highlight there are many listed in the falls reduction toolkit. It's important that we also recognize them. Looking at our patient's med list, we can check off that she takes diphenhydramine and over-the-counter. We can also check off that she takes doxazosin, an alpha blocker, oxycodone, an opioid, and paroxetine, an antidepressant, as well as zolpidem, a sedative hypnotic. Now that we have gone over some of the key fall risk increasing drugs and intrinsic risk, let's review the important steps of completing a medication reconciliation. By beginning, what Joint Commission has to say about them, it is no surprise that it is one of the national patient safety goals to maintain and communicate accurate patient information. It's a process of comparing a patient's medication orders to all the medications that the patient has been taking. Evidence has shown that discrepancies can affect patient outcomes. Specifically, 11 to 59% of discrepancies at admission and discharge has been considered for potential for harm. A systematic review showed that 66% of reduction in medication discrepancies and pharmacy-led medication reconciliation was found. Looking at this picture, we see that we have a patient coming from home to the hospital and a medication history is obtained. Then on days 1 to 4 of the hospital, the medication changes occur. Some of them are unable to translate over to a discharge. This is where we can get involved in discharge reconciliations, ensuring coverage and counseling and a safer discharge home. There are many ways to do a medication reconciliation, but this is one way that I've found that keeps me organized and is a gold standard. First, I develop a tentative list of medications based on patient's fill history. Then I speak with the patient to confirm that they have been taking their medications as a secondary source. The next step after completing the list is to compare what is prescribed inpatient and outpatient and look for discrepancies in the notes in the patient's chart if medications were intentionally held. Then we need to look for medications with a high fall risk, identify clear indications, identify medication-related adverse events, and clarify any duration of therapies. Next, we can make our clinical decisions based on our comparisons and communicate a new list to caregivers and the patient. On to our first case, which you will be answering in the chat box. TD is an 83-year-old male admitted to the emergency department on January 9 with a chief complaint of falls. We see on the left are the home medications per the 2020 MedRec that was completed by somebody on a last admission. And on the right is a medication history that we completed where we verified with the source between the patient as well as the pharmacy. How many discrepancies did you find between the initial home medications on the left and your home medication list on the right? I'll give you some time to answer. So good job. I'm seeing a lot of 5s. There are 5 discrepancies in the dosing of aspirin, carvedilol, insulin, and starting levocetirizine instead of levothyroxine, and tramadol instead of trazodone. As you can see, if these medications were ordered incorrectly inpatient, the consequences of the medications errors may be actually harmful to the patient. Now that we have reviewed some of the medications and medication histories, when we do a medication history, it's important that we explain why each medication was prescribed. As we see in this comic on the right is a patient explaining why each medication was started by their doctor. Oftentimes, the patient won't be aware of why each medication was started, and it is our duty to provide our expertise on medications and find out and deprescribe. In the American Geriatric Society Choosing Wisely's 10 Things question, many of them have to do with fall risk. Number 2, do not use antipsychotics as first line for agitation associated with dementia. 3, do not use benzodiazepines or sedative hypnotics as first line for insomnia, agitation, or delirium. 4, do not use medications besides metformin to target a hemoglobin A1C less than 7.5. 6, do not use acetylcholinesterase inhibitors for dementia without monitoring for benefits and side effects. 9, do not prescribe a medication without reviewing the current drug regimen. And 10, do not use physical restraints to manage hospitalized patients with delirium. Some alternatives are fall wristbands and alarms, and even more effective one-on-one and close observations. This diagram shows a backbone for a prescribing cascade. For example, an initial drug is prescribed, donepezil for dementia, then it leads to a new medical condition, bradycardia and urinary incontinence, in this case where oxybutynin is prescribed. Because oxybutynin can cause constipation, Senna is prescribed and a new medical device is added, the pacemaker for bradycardia. There are many ways to deprescribe, but the general backbone of the steps would involve first completing a medication reconciliation with indications for each medication, using geriatric tools to consider the risk of drug-induced harms and determine the necessity for deprescribing, assessing each medication based on the risk versus benefit and guideline recommendations, prioritize drugs for discontinuation, what is causing their side effects now versus what medications can we deprescribe in the future, and implementing a deprescribing plan and monitoring regimen. Did you know that 90% of patients are willing to stop a medication if their doctor says it's possible? It's crucial that we discuss the plan with our patient and provider. While we can optimize chronic and acute illnesses to control intrinsic factors, we do have a role in identifying medications that increase fall risk, deprescribing them, and suggesting alternatives. If a patient comes in with a fall, we want to prevent another one. And if a patient has never fallen, we want to prevent a fall, especially if they have risk factors as mentioned. I will be focusing on the fall risk-inducing drugs listed in the 2019 Beers criteria. These are the list of potentially inappropriate medications to be avoided or used with caution in older adults that may increase risk for falls, including anticholinergic agents, antiarrhythmics, antihypertensives, insulin and oral antihyperglycemics, benzodiazepines, CNS depressants, hypnotics, acetylcholinesterase inhibitors, anticonvulsants, and lastly, opioids and skeletal muscle relaxants. Going into further detail, this gives an overview of the stronger anticholinergic agents. The main ones to highlight are the antiarrhythmics, particularly disopyramide, which is not too common, antiemetics, such as meclizine, dicyclomine for GI agents, and first-generation antihistamines, which we may be preferring to replace with a second-generation one, such as cetirizine. For Parkinson's disease, we have benztropine, and many older adults presenting with urinary incontinence are inevitably prescribed oxybutynin, as well as antispasmodics. And of course, antipsychotics we should try to avoid when possible or select alternative agents. For muscle pain, cyclopenzaprine is also highly anticholinergic, and we should try to replace it with acetaminophen or lidocaine cream and patches. This demonstrates that cognitive impairment and anticholinergic side effect risk increase with the use of medications, higher doses, and total number of anticholinergic medications. One way to remember the side effects for anticholinergics, which we can also use when counseling patients, are hot as a hair, which can lead patients to feel febrile and hot to touch, dry as a bone, which can lead to dry mucous membranes and skin, blind as a bat, which can lead to blurry vision and cause falls, red as a beet, which can cause vasodilation and the face and the trunk of the body to become bright red, and mad as a hatter, meaning that older adults may present with delirium, hallucinations, restlessness, and falls. Case 2, TP is a 76-year-old female with a past medical history of dementia, diabetes, and urinary incontinence, admitted to the ED with a chief complaint of fall. She fell down while getting out of bed to grab a glass of water and was found down by her husband. She states that she has been feeling very thirsty and her vision is worsening. Blood pressure sitting, 125 over standing, 125 over 80, standing, 120 over 78, heart rate 75, CK 50, and blood glucose is 160. Now you can answer in the chat box which medication may be contributing to the patient's current symptoms. Lisinopril 5 mg daily, metformin 1000 mg twice daily, simvastatin 20 mg at bedtime, and oxybutynin 5 mg 3 times daily. I'll give you some time to answer. Excellent. The answer is D, which most of you selected. Oxybutynin is a urinary antispasmodic, most likely causing the patient's current symptoms, as thirst and worsening visions are anticholinergic side effects. I tried to ask this patient if they have urinary incontinence, did this medication help, and try to taper them off of it and monitor their symptoms. The answer is not A. While we can consider deprescribing lisinopril to aim for less stringent blood pressure goals, this is unlikely to be the cause for her current symptoms since she does not have hypotension and currently is presenting with the anticholinergic side effects. The answer is not B. While metformin can lead to hypoglycemia, the patient's blood glucose is normal, and not C, because as mentioned before, while simvastatin can lead to rhabdomyolysis, the patient's CK is normal and she does not have any muscle aches or pains. The next drug class to highlight are the antiarrhythmics. There is no doubt that atrial fibrillation causing uncontrolled heart rate and rhythm can contribute to falls. Potentially inappropriate medications to avoid includes both amiodarone and dronedarone. Amiodarone, however, may be appropriately used as first line in concomitant heart failure and atrial fibrillation if rhythm control is warranted. Dronedarone causes worse outcomes. Digoxin should also be avoided for first-line treatment of atrial fibrillation or of heart failure, but may be appropriately used as second or third-line agents, and if we do, the dose should be no more than 0.125 milligram per day. Lastly, disopyramide may induce heart failure and is also anticholinergic. In atrial fibrillation, we often need to make the decision to start rate and or rhythm control. A large retrospective study by Dalgard compared the composite outcome of fall-related injuries and syncope in patients on rate and rhythm control in older adults. Among approximately 100,000 patients with a median age of 78, they found after 2 years an overall composite outcome of 21%. And other significant findings were also that antiarrhythmic drug monotherapy had a 29% increased risk versus rate-lowering drugs alone. Antiarrhythmic drug with rate-lowering drug compared to rate-lowering drug monotherapy had a 46% increased risk than rate-lowering drug alone. Specifically, amiodarone had a 40% increased risk with the highest risk within the first 14 days. The key takeaway was that antiarrhythmic drugs, specifically amiodarone, had a significantly increased risk for fall-related injuries and syncope. Limitations, however, were that this was a retrospective study. Only 3 antiarrhythmic drugs were included, and the results were self-reported. For hypertension, while the goal for the ACC/AHA guidelines were less than 130/80 in community-dwelling older adults, for frail older adults with increased fall risk, it's important to consider less stringent blood pressure goals. The ones listed here are those to avoid as first-line agents for hypertension, but they can be used for other conditions. Loop diuretics may lead to falls by causing hypokalemia, as well as muscle weakness and hyponatremia, and therefore confusion. As for beta blockers, they can contribute to bradycardia, especially with concomitant acetylcholinesterase inhibitors such as donepezil. Alpha-1 blockers and alpha-2 agonists are also recommended to avoid as first-line treatment for hypertension. Non-selective alpha-1 blockers such as doxazosin and terazosin can lead to orthostatic hypotension by acting on alpha-1A, B, and D receptors. The prostate primarily has alpha-1A. Tamsulosin, on the other hand, is selective to 1A and safer. And lastly, alpha agonists such as clonidine and methyl-dopa can also lead to orthostatic hypotension because it is fast-acting and drops blood pressure quickly, and can also cause confusion and delirium. Case 3, which you can type the answer in the chat. HN is a 93-year-old male admitted to the ED with chief complaint of fall. He was watching TV, and when he got up, he felt dizzy and fell down. Blood pressure sitting was 135/80, and standing is 99/70. Heart rate, 80 beats per minute, CK 30, and blood glucose 130. Which medication may be contributing to the patient's current symptoms? A, atorvastatin 40 milligram at bedtime. B, clonidine 0.2 milligram 3 times daily. C, insulin glargine 5 units at bedtime. Or D, metoprolol succinate 50 milligram daily. I'll give you some time to answer. Yes, most of you put B, clonidine. Clonidine is an alpha-2 agonist which can contribute to the patient's orthostatic hypotension given the decreased systolic blood pressure greater than 20 and diastolic blood pressure greater than 10 between sitting and standing. The answer is not A, as this patient's CK is normal and he's not complaining of any muscle aches or pains. Not C, because while insulin can lead to hypoglycemia, the patient's blood glucose is also normal at 180, 130. And the answer is not B, because metoprolol can lead to bradycardia, but the patient's heart rate is normal at 80 beats per minute. So this would not be the first agent that we would consider deprescribing. While statins are not listed in the Beers criteria, it's important that we also note that atorvastatin, lovastatin, and simvastatin have the highest risk for muscle injury due to lipophilicity and CYP3A4 metabolism. Reasonable alternatives with the lower risk for muscle injury due to hydrophilicity are pitavastatin, pravastatin, and rosuvastatin. It is crucial that we do check for drug interactions with statins, as more than 50% of cases with statin-reduced rhabdomyolysis were actually due to drug interactions. A meta-analysis even showed that there were no difference in myopathy in older adults on a statin versus placebo. So statins should not be withheld unless a patient is intolerant. In practice, we can often consider drawing a CK to assess for rhabdomyolysis in patients admitted for falls on statins presenting with symptoms of myopathy and myalgias. Switching gears to diabetes, older adults tend to be prone to hypoglycemia, and for many, it's difficult for them to be aware of their signs and symptoms. In older adults admitted on insulin at home, we should consider decreasing the total daily dose by 20% inpatient and consider deprescribing antihyperglycemics, especially sulfonylureas. The Beers criteria highlighted both of these to avoid. Insulin sliding scale without basal insulin. While it is common that we do see the insulin sliding scale used alone in the hospital, our goal is to monitor their sliding scale intake, and if needed, start them on basal insulin. However, in the outpatient setting, this strategy is dangerous for patients, especially without taking into account their meal intake. Basal bolus closely mimics our body's insulin production and controls blood glucose more effectively. Oral agents that we should avoid include the sulfonylureas, especially the long-acting ones listed here, because they have prolonged half-life and increased risk for prolonged hypoglycemia, such as glimepiride, glyburide, and clopropropine. Upon deciding our patient's individualized A1C goal, we can address contributors to hypoglycemia, such as poor appetite, deem the patient is still at risk for hypoglycemia, then recommend deprescribing. Specifically, the agents most likely that are contributing to hypoglycemia, such as sulfonylureas and insulin. If the patient still needs an alternative agents, we can also recommend a safer alternatives. We can recommend, for instance, switching glyburide to empagliflozin or mixed insulin to basal insulin. As a pharmacist, our role would also be to, of course, renally dose adjust antihyperglycemics such as metformin and sitagliptin. Then we should monitor our patient's glucose and symptoms daily 1 to 2 weeks after each change. Case 4, WR is a 66-year-old male with a past medical history of type 2 diabetes and hypertension, admitted to the emergency department with a chief complaint of fall. He was found down in the kitchen, blood pressure 128/78, heart rate 77, A1C is 8%, and finger stick glucose is 55. Which medication would be best to recommend deprescribing due to increased risk for prolonged hypoglycemia? A, amlodipine 5 mg daily. B, glyburide 20 mg daily. C, losartan 100 mg daily. Or D, metformin 1000 mg extended release twice daily. I'll give you some time to answer. Yes, the correct answer is B, glyburide, because it has the highest risk for prolonged hypoglycemia, while the other medications are unlikely to be the source for the patient's hypoglycemia. Before considering tapering off metformin, I would also ask about the patient's food intake, obtain the renal function, and more finger stick levels since the patient's A1C is 8%, and per the AGS guidelines, as mentioned before, we would still continue treatment for metformin and not use additional agents to aim for an A1C less than 7.5%. Is hypoglycemia really associated with falls? Yes. This was a prospective cohort analysis that looked for the association between severe hypoglycemia and falls in 1,162 patients with type 2 diabetes, 149 of which had a mean age of 65 and severe hypoglycemic event. They found that there was a two times increased risk for falls in patients with severe hypoglycemia versus no hypoglycemia, with a hazard ratio of 2.23. They concluded that severe hypoglycemia is associated with a substantially higher risk for falls, and fall risk should be considered when individualizing glycemic treatment in older adults. Switching gears to CNS active agents, the Beers criteria also recommends avoiding 3 or more CNS active agents, and minimizing the number of CNS active agents. First, benzodiazepine receptor agonist hypnotics, or Z drugs, include isoplacone, zalopon, and zolpidem, which should be avoided in older adults as the risks can outweigh the minimal benefits, such as complex sleep behaviors, delirium, minimal improvement in sleep, and falls and fractures. I'm often surprised that after telling a patient about the risk for complex sleep behaviors, they reveal to me some of the behaviors they've experienced in starting this medication and were not aware that it was drug-related. This is where we come into play to ask if they have tried alternative agents such as melatonin and help wean them off if possible. As for how we would deprescribe, first we would find out if the patient was taking it for insomnia, which should be avoided regardless of their duration and for their age greater or equal to 65. We would then discuss and ensure the patient or caregiver are agreeable to deprescribing and taper, then eventually stop at slow reductions of 25% every 2 weeks, and plan that the patient also has some drug-free days as well and offer behavioral sleeping advice. We would then counsel and monitor for benefits and withdrawal symptoms and use non-drug approaches. Another class of medications to avoid in older adults are the benzodiazepines, which can be classified into short and intermediate ones, such as alprazolam, lorazepam, and temazepam, as well as long-acting benzodiazepines such as chlordiazepoxide, clonazepam, and diazepam. They have a black box warning with opioids, as well as risk for CNS depression, cognitive impairment, delirium, and falls and fractures due to their sedative effects via the GABA receptors. As for psychiatric medications, ones to avoid include tricyclic antidepressants, such as amitriptyline, doxepin greater than 6 milligrams per day, and imipramine, due to their risk for anticholinergic side effects, sedating effects, as well as orthostatic hypotension. If the patient is experiencing a side effect such as orthostatic hypotension, we could also suggest an alternative such as sertraline. We might see many of our patients coming into the hospital on these agents. If they're not currently experiencing side effects at the moment, it might be appropriate to continue for the duration of their inpatient stay and may not necessarily warrant an intervention, but if they are experiencing side effects, we can consider tapering them off the agent. A major focus in older adults are antipsychotics due to their box warning of cognitive decline and mortality in dementia. They inhibit dopamine and can also worsen Parkinson's disease. They're anticholinergic and can also increase risk for stroke. Certain situations where it might be appropriate to use them are schizophrenia and bipolar disease, as an antiemetic during chemotherapy and after failure of other therapies, and if patients are harmful to themselves or others at the lowest doses possible. Deprescribing antipsychotics can be especially challenging as we need to thoroughly assess whether the patient has an appropriate indication. And if not, we can recommend deprescribing. We can either ideally taper them and stop the antipsychotic at 25 to 50% dose reduction every 1 to 2 weeks, or stop the antipsychotic if the patient has acute side effects such as present somnolence. Then monitor every 1 to 2 weeks for the duration of the tapering for benefits and withdrawal. Anticonvulsants can also cause falls by causing dizziness, drowsiness, and ataxia, Severe's criteria recommends avoiding them in patients with recent falls or fractures unless they do have seizures. Carbamazepine and oxcarbazepine can increase risk for hyponatremia by increasing secretion of the aldosterone hormone. Barbiturates have a high risk for overdose even at low doses and dependence. Gabapentin and pregabalin through alpha 2 delta subunit inhibition can cause fatal respiratory depression. And we should avoid these with opioids unless we are transitioning. Last but not least, opioids, which should be avoided in patients with recent falls or fractures, except for acute pain. When we do a medication history, it's important that we also check the iStop prescription monitoring program to confirm the patient's home dose. Fentanyl and meperidine are significantly eliminated by the kidneys, and methadone has a long and variable half-life, making it hard to titrate. Meperidine can also cause neurotoxicity more so than other opioids. And tramadol has a lower seizure threshold and serotonin syndrome risk. The key is to start at low doses, and to help tapering off these agents, we can consider standing acetaminophen. To further emphasize our role as pharmacists in opioid stewardship and fall reduction, this was a retrospective observational multi-center cohort study in patients aged over 65. There were 68,000 patients with a mean age of 81, of which 3,000 had an opioid prescription in 2 weeks before a fall-related admission. They found that in patients with a fall-related injury on opioids versus no opioids, they had a 58% increased risk of hospital death. Fall-related injuries in opioids versus no opioids was also 2.4 times. In conclusion, recent opioid use was associated with an increased risk for fall and increased likelihood of death in older adults. Another class of medications to avoid in older adults whose syncope may be due to bradycardia are the acetylcholinesterase inhibitors, donepezil, rifostigmine, and galantamine. These can actually cause cholinergic effects, which can be remembered by sludge, salivation, lacrimation, urination, diaphoresis, GI distress, and emesis. They can also cause bradycardia through parasympathetic innervation of M2 receptors, many of which are located in the heart. It's important that patients follow up with their providers to assess if these medications have helped with cognitive impairment. If they're not beneficial, it may be worthwhile discussing to deprescribe them. Following this flow chart, has a patient been taking this medication for more than 12 months? If not, we can consider if the patient has a caregiver wanting to discontinue it, if the patient refuses to also take the medication, or if they are severely agitated or has other drug interactions or terminal illnesses, we can recommend deprescribing. If they have been taking it for more than 12 months, we can assess if cognitive impairment has worsened over the past 6 months, no benefits have been seen, or if the patient has severe end-stage dementia, we can recommend deprescribing. Deprescribing an acetylcholinesterase inhibitor, we can do so by slowly halving the dose every 4 weeks and monitoring closely. On to our last case, case 5. GH is an 83-year-old female with a past medical history of severe dementia, depression, and hypertension, admitted to the ED with a chief complaint of fall. She fell down at the grocery store and stated that she has been feeling dizzy often, especially when she stands up. Blood pressure 148/85, 90/70 standing, heart rate 49, and sodium level is 132. Which medication would be best to discontinue due to increased risk for dizziness? You can type the answer in the chat. A, aspirin 81 milligram daily, B, donepezil 10 milligram daily, or C, lisinopril 5 milligrams daily, D, sertraline 100 milligram daily. I'll give you some time to answer. Yes, the correct answer is B. Donepezil is most likely causing her dizziness as patient presents with orthostatic hypotension and bradycardia. It is unlikely A, because aspirin is unlikely to cause dizziness. The answer is not C, because the blood pressure sitting is within normal limits for the patient. Not D, because the sodium level is within normal limit without hyponatremia, which could also cause dizziness. Hernandez and colleagues conducted a retrospective study to determine the association between acetylcholinesterase inhibitors and bradycardia in approximately 3,100 patients versus 8,100 patients. They found that patients on acetylcholinesterase inhibitor versus no acetylcholinesterase inhibitor had an increased risk for bradycardia by 40%. 13% of the patients had a decreased heart rate by more than 10 beats per minute. Therefore, they concluded that acetylcholinesterase inhibitors are associated with an increased risk for bradycardia in older patients with dementia. That's why it's important that we monitor for bradycardia, as the increased risk is also found to be with increasing doses. We've talked a lot about what we do when a patient comes in for a fall, but what are some ways that we can also prevent them? These exercises I'll be discussing are in older adults that are likely not the frequently admitted ones to the hospital, and that they are able to tolerate physical therapy and do most ADLs independently. While it's important that we emphasize safe medication use, I also wanted to share the benefits of the Stay Safe, Stay Active program, where exercises have shown to be improving the balance and reduce fall risk by 40%. Tai Chi is another great exercise that can help reduce falls by up to 49% with the Moving for a Better Balance program. And lastly, the Stepping On program has shown to decrease fall risk by 31%. I had the pleasure of attending one of these live and complete the exercises with the older adults. This is an opportunity for pharmacists to get involved in educating our community, as the program is several weeks long and goes over risk appraisal, introducing balance and strength exercises, how to move safely in the home, how to reduce hazards in and around the home, how to move safely in the community and use safe footwear, the benefits of vitamin D and calcium, medication management, and a follow-up home visit. To summarize the information we talked about today, older adults are prone to fall secondary to chronic and acute illnesses, environmental factors, and medications. Alongside with the interdisciplinary team, we can identify environmental risk factors for falls in older adults and provide patient and family education. Thorough medication reconciliation and review is essential in optimizing acute and chronic illnesses and preventing future falls. It's important that we also identify potentially inappropriate medications, recommend discontinuation of culprit medications, and suggest pharmacologic and non-pharmacologic alternatives to help our patient one fall at a time. These are my references, and that concludes my presentation. I'll now open the floor to any questions.
Thank you, Shireen. That was a wonderful presentation. While we're waiting for our participants to type in their questions, I was wondering, for many of the medications that you're tapering off, that are required for deprescribing, what strategies do you recommend to ensure that patients continue on that taper?
Great question. Thank you, Safa. In terms of making sure that patients continue their taper, sometimes this can be a challenge without appropriate follow-up. Currently, I work in an inpatient setting. However, during my PGY2 geriatric residency, I had the pleasure of completing follow-up calls. And I did notice oftentimes on my follow-up calls that patients forget to address with their primary care providers to continue the taper unless they are following with the geriatrician. So I think that follow-up calls would be the ultimate way to ensure that patients are continued on their taper, as it's important that we provide support and monitor for the withdrawal symptoms.
Oh, that's a great suggestion. And does your hospital ever also communicate with the patient's primary care provider before they are discharged?
Yes, currently my hospital actually, we communicate with the primary care provider if they are within our health system. Otherwise, we would ensure that providers state the patient care plan in their discharge summary to provide appropriate instructions.
Okay. And we have another question for you. In your current practice, how do you overcome provider pushback to deprescribing recommendations? That's a great question.
Thank you. So oftentimes, especially in the inpatient setting, we tend to focus a lot on what can we do to make the patients better and add additional medications. It's important as pharmacists that by stating the adverse drug reaction that the patient may have due to a medication, emphasizing the use of the Beers criteria, American Geriatric Society guidelines. Through this way, we can hopefully overcome the pushback. For instance, some recommendations in the internal medicine inpatient practice. I've completed our deprescribing donepezil, where a patient presents with orthostatic hypotension, deprescribing clonidine, as well as making sure that patients are not started as first-line agent on digoxin for atrial fibrillation and heart failure, and try to start with metoprolol first. Some other recommendations would also be that we are patient with ourselves in terms of deprescribing, as the providers might not always be receptive, but once they see positive outcomes in our patients, we can develop a good rapport.
Thank you so much, Shireen. That is a great suggestion. And I am sure with persistence, they'll see the value. So our next question is, what are some strategies or approaches to make sure the medications we deprescribed I'll reread that. What are some strategies or approaches to make sure the medications we deprescribe are not restarted upon discharge?
That's a great question. Oftentimes when I review the discharge medication regulations, the medications we deprescribed inpatient are accidentally restarted. So by speaking directly to the provider and stating patient was deprescribed this agent inpatient due to so-and-so adverse drug reaction, then I would recommend stopping this on discharge. The provider would be more receptive. For instance, I've noticed insulin doses that are not adjusted on discharge, glyburide that's continued on discharge, or donepezil continue on discharge in hospice patients. So this is where we can come in by speaking directly to a provider and ensuring the changes are made.
Well, thank you so much, Shireen. If there are no more questions, I will turn it over to, oh, I'm sorry. I just realized there's some other questions. I apologize. So our next is what's a successful strategy you have with suggesting benzo tapers in elderly who state that that's the only thing that can manage their chronic anxiety?
This is definitely a challenge in discussing with older adults with suggesting benzodiazepine taper, as older adults can tend to be dependent on them. One successful strategy is to ensure that the patient has an appropriate psych follow-up, especially with a specific psychiatrist that specializes in speaking with older adults, that can ensure that the patients feel like they are heard, and through this, hopefully start an SSRI and slowly taper off the benzodiazepine. And I think just by making sure that the patient's caregivers are also on board with not sedating them with the benzodiazepine and not giving in, making sure that patients don't have access to them, we can make sure that the patients do not continue their benzodiazepine.
Great. So our next question, as part of your transitions of care program, do you utilize televisits or follow-up calls? Do you have any PharmDs embedded in the outpatient clinics?
Yes, currently as part of my current transitions of care program, I do follow-up calls for certain patients who have had a follow-up call by a care manager and they have a specific question, adherence concern primarily focus on heart failure, COPD, stroke, and diabetes. I would also sometimes do my own follow-up calls to ensure that patients have picked up their medication if they do have adherence issues. We do actually have some PharmDs embedded in our outpatient clinic. Some of them are on this presentation as well. They're CDTM pharmacists in the primary care setting. And sometimes I do try to hopefully incorporate successful transitioning by working with them on some of our mutual patients.
Thank you. Our next question is, how would you respond to the addition of medical marijuana for severe chronic pain in studies that may have assessed fall risk when THC was added to the regimen?
That's an excellent question. I unfortunately don't have too much experience with hands-on experience with medical marijuana, but when patients who are currently on it state that they are feeling less anxious, it's gotten them off of benzodiazepine, they're feeling less in pain and came off opioids, I would encourage them to continue following up with their provider who prescribed the medical marijuana.
Great. Now, our next question. Most pain management physicians prescribe opioids and gabapentin concomitantly for chronic pain in cancer patients. This combo helps to lower opioid doses, yet there's the increased risk of falls and other interactions, as you mentioned in your presentation. Do you have any comments or strategies if you feel like it needs to be, if one needs to be tapered off?
Mm-hmm. In terms of managing chronic pain, specifically in patients with cancer, the Beers criteria for opioid use does not necessarily apply to them. However, it's important that we do monitor for their risk for falls, how sedated they are, and how much opioids they're using. For instance, if they do have gabapentin, high dose, as well as oxycodone 5 milligram every 6 hours as needed for pain, we would consider seeing how much oxycodone they're using and slowly taper off the opioids if they are not using it as much as before.
Okay. Is there any value in switching a sulfonylurea to glipizide if a patient has no history of hypoglycemia?
If the patient has no history of hypoglycemia and they're able to tolerate the sulfonylurea, then I would be less likely to push for deprescribing it. I would less likely switch them over to glipizide since there are more effective agents that are available. For instance, on the telemetry unit, many of our patients have concomitant heart failure, so I would suggest switching over to empagliflozin instead, or alternative agents rather than another sulfonylurea.
And our last question, do you have any thoughts on the use of CBD oil for anxiety or pain in the elderly?
For anxiety or pain in the elderly, I think it's one important consideration. I would not be the one to recommend using it, is if they are able to make sure they are putting it on properly, depending on the form of the CBD oil. If they are currently on it and say that it's been effective, then I would recommend continuing it. But since it's not something that we would necessarily start in the hospital, I would prefer to consider lidocaine cream or patches first, and speaking to the patient's caregiver to make sure that they are not having any side effects from the CBD oil and are using it appropriately.
Okay. Thank you so much, Shireen. That was a wonderful presentation. I know that I learned a lot from my own practice. So next we have our next speaker, John Noviasky.
Yes, thank you very much. And I did want to help answer some of those questions that Shireen got as far as deprescribing and the practitioners being resistant to it. One of the things that we did in the TCU is we sat down with the prescribers and came up with a procedure for different medications to be deprescribed by the pharmacist that are on the TCU automatically. So for example, in orthopedics, one of their order sets includes a skeletal muscle relaxant. If the patient's not using it for a few days, we just automatically get rid of it. So that's one way that you can avoid prescriber issues. And I think benzodiazepines came up a couple times, and that's really a problem. If somebody comes in and they've been on benzodiazepine for 10 years, it's going to be a tough thing to even suggest during their hospital stay. Sometimes we'll just tell them at discharge to the outpatient prescriber, maybe you can discontinue these. On the other hand, if it's something that we're starting inpatient, then we may try to deprescribe them before they leave. But benzodiazepines are a very, very difficult animal to handle. But you know, that was a great presentation, Shireen, and let me see if I can share my slides.
Thank you, John.
Yeah. Does everybody see my slides?
Yes.
All right, great. So tonight we're going to go over geriatric emergencies, and I have collected for you various evidence-based medicine, such as meta-analysis. I have a Cochrane analysis, randomized controlled trials, cohort analysis when there aren't randomized controlled trials, and I have one retrospective review that we're doing at our institution currently on haloperidol 0.5 milligram that I'm going to go over. And I want to cover geriatric emergencies. The ones that I want to cover are those adverse drug events that bring patients to the hospital, to the emergency department. I want to cover falls, and I know Shireen did a great job on falls. I have a little bit more to add to that discussion. I also want to cover delirium and the prophylaxis and treatment of delirium. Mostly what I'm going to cover is the use of antipsychotics and delirium. And then finally, we're going to go over a quality initiative at our hospital that is currently in place. And I want to show you what we did, what was successful, what wasn't, and then go from there. And as you can see here, this is Dr. Chacho in the Geriatric Emergency Medicine Department at Community Campus. And about a decade ago, Dr. Chacho sat down with my director and I and said that he's opening a geriatric emergency medicine department and he needs a couple pharmacists to be in that department. And we were like, okay, you know, how often does that happen where a provider comes to you and offers you pharmacist positions? It was a great day. So we hired a geriatric pharmacist. And then a few years later, we started a geriatric pharmacy residency program. Dr. Kelly Yulin started that program. And we are very geriatric based. We have the emergency department. We also have the transitional care unit, and what we also call the TCU. We have the acute care of the elderly team, the ACE team, and that is a team that meets Monday through Friday. And we try to prevent delirium in patients. And if a patient comes in with a fall, we'll try and review and make recommendations to the team on what can prevent that fall. And that's what we're doing. We're really based in geriatrics. We also have in the works a geriatric floor that has been delayed because of COVID, but that is in the works as well. So this overview I've just covered, and I do want to cover at the bottom here all these abbreviations, because sometimes when I get to the slide and I've got an abbreviation there, I'm like, what did I mean by that abbreviation? So if I read it here now, hopefully I'm going to remember it then. ADE, adverse drug event, ADL, activities of daily living, BDZ, benzodiazepine, DOACs, direct oral anticoagulants, ED, emergency department, IADL, instrumental activities of daily living, NTI, narrow therapeutic index, PBA, pseudobulbar affect, PIM, potentially inappropriate medication. That last one is going to come up a lot. So first covering adverse drug events, and they're a huge expense, $30 billion a year. And that was in 2007. This is from a 2007 study published in Annals of Internal Medicine. And they wanted to review how does the Beers criteria match up to those patients getting into the ED. And originally I wasn't going to cover the Beers criteria as a topic, but it is mentioned here, and it really is a cornerstone of geriatric pharmacotherapy. It also is used in quality measures and CMS, so it's kind of important for us. The last edition was published in 2019, and if you look at the expert panel, you will find nobody named Beers in that panel. So I'm like, so where does this Beers criteria come from? Dr. Mark Beers first published a list in 1991 based upon some research he had done in the 80s and other people's research, and was publishing it every few years until his death in 2009. He died at the age of 55 as a complication of diabetes. He must have had pretty severe diabetes. In 1990, he actually had to have his legs amputated because of diabetes. So I think it's so interesting that this man who's really created a cornerstone of geriatric pharmacotherapy never made it to the older adult himself. In 2011, AGS took it over, and every 3 years, they're publishing an update. Just to give you a reference or idea of how many references they're using, they used almost 18,000 references from the previous update. They ended up using 281 observational studies, 29 clinical trials, 67 meta-analysis in the 2019 update. So it just shows you how evidence-based this particular list is. And they have various tables. The main one for us is that they list the PIMS, the potentially inappropriate medications to avoid by organ or category. So by category, for example, anticholinergics and benzodiazepines. The next part of that table is the rationale why we want to avoid it. For example, anticholinergics, confusion in dry mouth, etc. For benzodiazepines, cognition impairment, delirium, etc. And they'll also have caveats in there. So for benzodiazepines, maybe it's okay for seizure patients, patients going through alcohol withdrawal, or with severe generalized anxiety disorder. They'll also give you the level of evidence. For example, in these two avoid categories, it is moderate evidence, which is a randomized controlled trial with limitations, or well-designed controlled trials. And the strength of their recommendation is strong in both of these PIMS to avoid. The next big table that they have is PIMS by disease, and Shireen covered a very good one for falls. For syncope, these are the medications that are considered to be careful with: acetylcholinesterase inhibitors, alpha-1 blockers, and that's because of orthostatic hypotension and bradycardia. The next big table are PIMS to be used with caution. So the first big table is PIMS to be avoided. This one is PIMS to be used with caution. One example from that is dextromethorphan quinidine, and this was a very controversial drug a few years ago. I'm not really sure if it's still controversial, but in the Beers criteria, they felt that it had limited efficacy in dementia, not PBA, pseudobulbar affect, but in dementia, it has limited efficacy and an increased risk of falls. The last three big tables here, drug-drug interaction, renal disease, and drugs with anticholinergic property. I believe as pharmacists, we have a very good handle on these. I did pick one that was kind of interesting for the drug-drug interaction, and that is the use of loop diuretics with alpha-1 blocker. Apparently, there's an increased risk of urinary incontinence above using just a loop diuretic, so that's kind of interesting. For the renal disease, I thought the duloxetine was a little bit interesting. We don't often think of the antidepressants as an issue with our renal patients, so duloxetine, you might want to be considering that. And as far as drugs with anticholinergic properties, I think Shireen did a very good job with that. Oh, and if you want to get a full text list of that, I could have had the whole HTTP reference there, but really all you got to do is Google Beers criteria 2019 and add PDF on there. When I did that, it came up as the second listing. So back to this study in 2007. What they did is they looked at a national adverse drug event database from about 60 hospitals over 2 years. What they came up with is about 4,500 adverse drug events, and they estimated almost 200,000 adverse drug events yearly based on that information. Now, in this particular study, they felt that only about 4% involved Beers criteria medications, so not much. Instead, they picked the 3 medications that were the top offenders: warfarin, insulin, and digoxin. And as far as risk for these 3 agents, for every 100,000 prescriptions, 206 patients would end up in the ED, versus 100,000 prescriptions for beers and about 6 patients ending up in the ED for those medications. Now, in 2007, perhaps insulin sliding scale wasn't a part of the Beers criteria, which it is now, at least in the 2019 edition. Insulin sliding scale is an avoid medication when you're not using it with basal insulin. And digoxin is also an avoid if it's used at greater than 0.125. So this information might have changed if it had been described today. As far as this study, you see here, warfarin, insulin, and aspirin are actually the top 3 agents, not warfarin, insulin, and digoxin. So why did they pick warfarin, insulin, and digoxin? The reason was because when they looked at the adverse events, or what actually happened to the patient with aspirin and clopidogrel, it wasn't as serious as what happened with patients that were admitted to the ED on warfarin, insulin, or digoxin. Also, if you think about it, warfarin, insulin, and digoxin, perhaps if we monitored more, we might be able to prevent their admission. So that's why they picked warfarin, insulin, and digoxin. The purpose of this graph is really just to show you that warfarin, insulin, digoxin are really the biggest offenders as far as leading to ED admissions, whereas for the number of prescriptions, it's the smallest of all the categories that they were looking at. So that was from 2007. I wanted to get more contemporary. I found this one from 2017, which was pretty good, at least initially, that I thought. And then there was a big limitation that I'll describe in just a moment. It looked good. There's like 90,000 patients, about 80 years old, and they're using 2012 Beers criteria in this case, so we're getting more contemporary. About 60,000 of them were not using any potentially inappropriate medications, so that's per Beers criteria. About 34% were using 1 or more. About 7% were using 2 or more. So the main limitation of this study, as opposed to the 2007 study, is that the hospitalization counted no matter what they were coming in for. So if they were coming for a UTI, for pneumonia, that counted as a hospitalization. It didn't have to be drug related, unlike the 2007 study. As far as PIM utilization, you'll see here, if you were on a PIM, half of the time it was a benzodiazepine. So heavy use of benzodiazepine in this population. Next one is nonsteroidals, cardiovascular agents, anticholinergics, tricyclic antidepressants, skeletal muscle relaxants, and sulfonylureas. And this was from 2017. I can tell you, I haven't seen chlorpropamine, in a couple decades. I'm not sure about you. And even glyburide, I don't see very much at all anymore. It's really dropped off in the past few years. So there is always an issue of when the studies are published versus what your current practice is. As far as this study from 2017, yes, if you were on more PIMs, you were at increased risk of being hospitalized. If you were on 1, you had a 13% increased risk versus if you weren't on any PIMs. If you had 2 or more, you were at 20% risk, increased risk, as if you were, compared to if you weren't on any PIMs. For anticholinergics, your risk increased 13%. For cardiovascular agents, 20%. For benzodiazepines, about the same. Now, what's interesting in this study, if you're on a nonsteroidal, your risk of being hospitalized actually decreased by almost about 25%. So that's kind of interesting from 2 factors. They surmised maybe it was the cardiovascular benefit of the nonsteroidals. They weren't really sure. The other idea they came up with is maybe it was being used by healthier patients. So if you can imagine the older patient taking a dose of Aleve and then going out jogging 5 miles, maybe that's happening. Not really sure. But what I do know is when they put this study together, they excluded nonsteroidals in this final outcome, their major outcome. And I think they did that because if you look at a 25% reduction in hospitalization, and remember, nonsteroidals were the second most common PIM, I don't think they would have found an increased greater risk with the PIMs of being hospitalized. So I think that was kind of an interesting manipulation of data in that particular study. Reviewing these two studies, 2007, 2017, warfarin and insulin and digoxin certainly are important medications that convert the outpatient to an inpatient. The anticoagulation landscape certainly has changed. Warfarin we still see, certainly not as much as 5 years ago, 10 years ago. And so if we're using more DOACs, is that resulting in less hospitalization? It appears so. I looked at a comparison of DOACs versus warfarin in 2019. All-cause readmissions and hospitalizations were decreased. So if this same study were repeated now, that would be changed, I believe. Another big limitation of that study is they were looking at emergency department admissions, not at adverse drug reactions that went to the PCP, or if you went to urgent care. And if an adverse reaction is gradual in nature, probably you're not going to present to the ED. The 2017 study generally showed that if you were on more PIMs, you're more likely to be hospitalized, but that could be because you're sicker. So you're on more of the PIMs. Also, that non-steroidal component is kind of bothersome, but the other big limitation of the 2017 study as compared to the 2007 is that hospitalization was not necessarily related to any medication. So the next big area I'm going to cover is about falling, and Shireen did a great job about falling. I will say that when a patient falls, it is a major life-changing event in some way. It can be determining where you're going to live, how you're going to live, how you're going to feel thereafter. And if it's not the first fall, it may be the second fall, it may be the third fall that's going to do it. But at some point, it most likely will. So falls are a huge part of the older patients' issues. And multifactorial interventions are effective, as was mentioned by Shireen. These are the multifactorial interventions, the ones that we're most interested in to see how they're doing as far as falls, our medication review, and orthostatic blood pressure. And I like this study. It was titled, actually, Will My Patient Fall? It's from a publication published in 2007 in JAMA. So they did a multivariate review, which is as opposed to a meta-analysis, which summarizes all the results. Essentially, they gave a summary of all the different studies and the results, and then let you decide what you think about them. They did make some general summaries, such as falling in the past year predicts another fall likelihood ratio of over 2. They felt that the most consistent predictor amongst all these studies were clinically detected abnormalities of gait or balance, which doubled your likelihood ratio of falling by about 2. All those other variables were not consistent among the studies, which include ours, which are the medication variables and orthostatic hypotension. So, looking at medication-related studies that were in this particular review, there were 11 of them. And I'm just going to summarize likelihood ratio on the right here. And it's a probability of finding in patients with disease over the probability of the same finding in patients without the disease. So in this case, the disease would be the variable that we want to look at. So greater or equal to 4 medications, and the probability of the finding is the fall. And that determines your likelihood ratio. So if your likelihood ratio is large, a large number, that's more likely that that disease caused that fall. And if it's small, if it's less than 1, then it's less likely. If its likelihood ratio is 1, then it doesn't mean anything. So in Campbell's study, they found that greater or equal to 4 medications was 2 times your likelihood ratio of falling and taking psychotropic medications. Teneti, it was benzos, phenothiazines, or antidepressants. And leukine, it was benzos or antidepressants. So we do see a theme coming up here. I want to review quickly heterogeneity as it pertains to meta-analysis, because that's what we're going to start looking at. And heterogeneity is important to determine as it defines how similar or dissimilar the studies are that they are comparing. And what you want is a lower number. 25% or 0 to 0 is good. 75% to 100% is probably not good. The I-squared is what we're going to look at in these meta-analysis, and that's also called inconsistency. So lower is better when you want to look at heterogeneity. We want them to be more similar than dissimilar. And for example, if I had two similar design studies and my rate of mortality is 90% in one and 10% in the other, that's pretty dissimilar. So I would want to know that when we're summarizing the data. So what I did here is I just cut to the chase. I gave you all the results. And these studies, actually, it's two separate studies by Sipala. And there's another one that he did looking at other medications. But these are the two meta-analysis. And you see the I-squared here, pretty high in some of them. But I'm just going to go through the medications that he found that were positive for increasing falls: antipsychotics, antidepressants, benzos, anti-seizure meds, opiates, and non-steroidals in this particular study. Now, the interesting thing is that antidepressants come up here, and SSRIs, actually, it was a 2 odds ratio of having patients fall. I discussed this with my geriatrician, and she says that, well, depression can increase your chance of falls, and treating the depression can increase your chance of falls. So in about 9 months after treating a depression, you should probably reevaluate if they need to continue on that antidepressant. And I can tell you in our TCU, we have an active deprescribing procedure. We do not look at deprescribing antidepressants. The only antidepressant we do look at is paroxetine, because it has a high anticholinergic burden. We would rather see you on a different SSRI. So I thought that was pretty interesting as far as antidepressants. Part of the theory may be that once you're started on an antidepressant, you're going to be more active, move around more, and oops, then you're falling more. So that's part of the theory. So we looked at a lot of medications, and some of them have a positive effect on falls. We look at anticholinergic burden a lot. We add it up, and actually in our EPIC, it is automatically added up for us now. So it's a nice screening tool. It comes up in one of our patient summaries, and I can look at the anticholinergic burden outpatient and inpatient. It just gives me the number. So that's kind of nice. But in other words, we spend a lot of time on anticholinergic burden. But is that a factor in falls? I found this study that was done in a VA population, and there was two main groups that they looked at, retrospective and prospective group. The main difference between these groups is that the retrospective group was older, they had more cognitive impairment, and they had a pretty high falls rate at baseline compared to the prospective group. In this study, they summarized peripheral effects as dry mouth, dry eyes, and constipation. For central effects, they summarized as falls, dizziness, and confusion. So I wish they had split out falls more, but they included it with central effects. So in this study, they found a positive effect of anticholinergic burden and falls for the retrospective group and the prospective group. However, in the prospective group, it was not statistically significant. In both groups, they both had the peripheral effects. So to summarize falls, they are multifactorial, and some studies show that medications are very important: psychotropics, benzos, anticholinergics, and they make sense. These patients are sedated, they're confused, have orthostatic hypotension, so you would imagine that they would be falling. Now, why didn't some of the studies find medication as a factor? And I've seen this when reviewing medications with patients, is they may take a dose of Zolpidem and it did terrible things to them, and they never took another dose. So they are auto-selecting themselves out from taking that type of medication they are not going to fall from that medication. So maybe that's why more studies don't find that as a factor. And we want to think that if we take patients off these fall risk medications, that we're going to decrease their rate of fall. So let's look at the evidence for that. And in my bottom right-hand corner here, you see this patient came in with all these medications. And then after we were done deprescribing, they only had 3 left. I would say that's a very positive deprescribing procedure there. So this was a meta-analysis looking at deprescribing fall risk increasing drugs. It was a meta-analysis of 5 randomized controlled trials of about 1,300 patients, most having falls history. So to look at this study, I want to review the forest plot. And I tried to find how did they come up with the name forest? I did see some mention of a Dr. Forest, but I also saw some mention of maybe it has to do with an actual forest with trees. I'm going to go with that definition. And if you look at the B line, this B line is the trunk of the tree or the line of null effect. And so you follow my trunk there down to the dirt here, which is at the bottom. Then A is an individual study that's been added to my tree, and it is a tree branch. So the length of the branch is the confidence intervals. Then at this dot here is the point estimate and also gives us the sample size. So the point estimate is directly in the middle. So if you were to draw a line in the middle of this box, you would know the point estimate of that branch. And if the box size also determines the size. So the larger the box, the more the sample size compared to this branch here. This diamond here is the fruit of the tree. And if you look at the north and south poles of the tree and draw a line through that, that is the point estimate summary of all the branches. And then the left and right are the confidence interval summary of all the branches. So if you want to focus on something in a forest plot, you can focus on the fruit of the tree. And that's what we're going to do in here, is looking at falls rate. And whoops, it covered the line of null. So all of these interventions for deprescribing didn't make any difference in these studies that they summarized. Oops. Oh no. Okay. So that's kind of disappointing, I would say. But if we look at the individual branches, we do find this one that does have a positive effect when they were deprescribing, Campbell 99. So we're going to look at that one more in detail. The major limitation of all these studies was that the patients that actually completed discontinuation of a fall risk increasing drug was very low. Only 10 to 40% actually was successful. So that's a very, very low response rate. And I think that's a major limitation for these studies. So let's look at the study that was positive and was done and published in '99 by Campbell. It was completed in New Zealand over about a year's time period. And they looked at 2 major groups, medication withdrawal versus no medication withdrawal. There was also an exercise component to it as well. And if you notice, the overall sample size of the study was only about 100 patients. So this was considered a pilot project. I did try to find if the actual large study was ever done. I could not find it. And it's probably because that it is a pretty complex study, and I'll show you that in just a moment. As far as the baseline population, they were on about 5 to 7 meds. A lot of them had fallen previously. A lot of them were using benzodiazepines. And it was about 50 in the med withdrawal versus 50 in the no med withdrawal group. So this is how we decreased the patient's psychotropic medication. This is how we withdrew it. They were withdrawing any benzodiazepines, hypnotics, antidepressants, tranquilizers. And the way they did it is over time. So for example, if you're on alprazolam 0.5 milligram and you're involved in the study, you give me the alprazolam 0.5 milligram as a pharmacist, I crush it up, put it in a capsule, give it back to you. In 2 weeks, you give me that same alprazolam, I crush it up, now I'm only giving you 80% back. And every few weeks, I'm decreasing that by 20% until after 14 weeks, you're not on any alprazolam anymore. So that's what I mean about complexity of the study. And if they were on benzodiazepine and an antidepressant, they did it with both. So there's 2 separate capsules that they got to keep track of and decrease by 20% and all that. So it's quite a complicated study, I believe. And even with this really nice dose titration, and the patient doesn't even have to be involved in it, they're just taking that same gelatin capsule, they didn't like it. Almost half of the medication withdrawal group wanted out. They couldn't sleep or whatever. Even when we weren't changing the patient's medication, a quarter of them wanted out of this study. So we weren't even touching your psychotropic and they didn't like it. So that's a major limitation for this kind of study. Despite that rate of patients dropping out, the med withdrawal group did do better at 0.5 falls a year versus if you didn't withdraw the medication at over 1 per year. And that was statistically significant. The exercise group also did very well. So there is evidence that falls can be decreased if medications are withdrawn. I would say it's much, much easier to say that than actually do that. And in our deprescribing on the TCU, I can tell you that we're happy with it. It's had some good findings, but we also are not following those patients out in a couple months or 6 months or a year. Maybe they're just back on with the medication that we got them off, I'm not sure. So we know that these medications can cause falls. We know that it's hard to get them off of the medications that can cause falls. I want to put the question to you is, how do we avoid starting them on these medications at all? I think that's a real key to avoiding the issues that come down the road. The next big area I want to cover is delirium. And I've got this all in one slide, and I think that's enough for this presentation's purposes, but the delirium is a huge topic, really. It is acute brain dysfunction, so it's something that's happening now, then in a change in mental status. ICU patients are really at risk. Almost every other patient is going to have some form of delirium. And as far as definition, when I think of delirium, I think of the patient pulling out their IV line, they're pulling out their NG tube, they're pulling out their urinary catheter, terrible things, or they're seeing spiders and they're very upset about that. But that type of delirium is actually a small part, only about 2% of delirium. The more common forms of delirium are what we call the hypoactive, the withdrawal, the flat affect, the apathy, the quiet patient really is the more common delirious patient. And then there's a certain component of mixed, about 50% are mixed. So they have the hypoactive component and then the occasional issue of seeing the spiders or whatever. So we know that delirium is terrible. It's terrible on the patient, it's terrible on the patient's family. There's a bunch of negative outcomes associated with delirium. So if we could prevent it, wouldn't that be great? So this study published in 2018 was randomized, double-blind, placebo-controlled. They reviewed almost 16,000 patients that were going to be in the ICU for 2 or more days. And then they had to exclude a whole bunch of them. Some of them, they already had delirium, so we can't really study prophylaxis if they already have delirium. If they have dementia, we weren't going to study them. If they're already taking an antipsychotic, we couldn't study that because we're going to be adding an antipsychotic. Some of them already had prolonged QTC, so for safety reasons, we're not going to add an agent that can prolong potentially your QTC. They ended up randomizing about 1,800 patients, mean age of 66.6 years. They wanted to stress that this was performed in the Netherlands, where non-pharmacologic interventions are standard, which include those things listed below here: improving your sleep, noise reduction sedation protocol with less sedation, reducing use of benzodiazepines, waking the patient up, and hearing and visual aids. And I did discuss with my intensivist, and they do try to use most of these in our ICU. So this is how the study went. So we ended up randomizing 1,800 patients to 3 different groups, 2 doses of haloperidol, and 1 to placebo. On the far left here, you see that they were getting 1 milligram haloperidol every 8 hours, and this was IV, versus 2 milligram of haloperidol every 8 hours versus placebo. Now you will notice there is a difference in sample size between the 1 and the 2 milligram group, and that's because during an early analysis, they found that the 1 milligram group, they just weren't doing as well as the 2 milligram group, so any further entrants, they just send them over to the 2 milligram group. I will note that most of the patients completed the trial, which means that potentially they could be on haloperidol at 1 or 2 milligram for every 8 hours for 28 days, which I think is a lot of haloperidol, or until their ICU discharge, or until delirium occurred. As far as those doses of haloperidol, either 1 or 2, they would reduce the dose if you were over 79 years old. They would put it in half, or if you were lightweight, less than 50 kilograms, or if your bilirubin was high, they would decrease it by 50%. So this is where statistics is great, because you don't really need to know any statistics to know that these lines are all the same. So their primary outcome, that of survival, was no different at 1 month or 3 months. Didn't matter if you're on placebo or any dose of haloperidol. So there appears to be a lot of information on this slide, but I'm going to walk you through it. I'm going to make it really very simple. If you looked at this 3rd column, what they're doing is they're comparing the medians of 2 milligram haloperidol versus placebo. And if you look at them, 0, 0, 0, 0, 0, 0, it's either 0 or crosses 0, meaning that there was no difference between haloperidol and placebo. Now we can look at the outcomes, remembering that there's no difference. Incidence of delirium, number of delirium-free days, number of days to occurrence of delirium, no difference. Length of stay in the ICU or in the hospital, no difference. ICU readmissions, all of these various variables, no difference. So the prophylaxis doesn't look like it worked. How about treatment with haloperidol or ziprasidone or placebo? Let's look at that. This was a study published in 2018, another randomized double-blind placebo control. They looked at about 20,000 patients. They ended up enrolling about 1,200. About half of those developed delirium. Now, this is where that first definition comes in play. Most of them were hypoactive. So most of them were the apathetic patient, the lethargic patient, not the ones pulling on their lines. Only about 10 or 11% were pulling on their lines. So I think that's important to note. They ended up having about 200 in each treatment group. As far as dosing, if you developed delirium, we started you off at haloperidol 2.5 milligrams every 12 hours, and this again was IV, or 1.25 milligram every 12 hours if you were over 70. Ziprasidone, it was 5 and 2.5. So if you develop delirium, we're going to give you that starter dose and then increase your haloperidol dose up to 10 milligram every 12 hours, 20 milligram daily max. So they were not fooling around with dosing with haloperidol. This was definitely treatment doses. Ziprasidone up to 40 milligram a day. And if your delirium resolved, then we tapered you off over a day or a couple days. The outcomes that they were looking at were very similar to what we just saw in the study looking at delirium prophylaxis. Again, you don't need to know much statistics or any statistics to know that these are all overlapping. So no difference in those main outcomes that we wanted to see of days alive without delirium or days with delirium between ziprasidone, haloperidol, or placebo. Ziprasidone, haloperidol, placebo. It just didn't work. So keeping that in mind, I want to look at a Cochrane database looking at delirium treatment. And I love Cochrane database. They're huge. They're 120 pages. This one I did not print out. It's just too many pages. 10 authors, 2 are pharmacists. They look at almost 8,000 citation and about 1,900 patients met inclusion criteria. And they were looking at randomized controlled trials, looking at treatment of delirium. So looking at the fruits, as far as duration of delirium, there was no difference if you used an antipsychotic, typical or atypical. They all crossed the line of null. Now you notice this large green box, Gerard 2018. This is actually the study that we were just looking at. And this is my main issue when I'm looking at meta-analysis. I usually end up looking at these individual studies anyway. It's nice to see a summary, but then you probably will end up looking at more than just a summary for your results. Mortality, again, no difference between groups if you used a typical antipsychotic or atypical or placebo, just didn't do anything. QTC prolongation, they felt that the absolute effect was positive as far as using a typical antipsychotic and QTC prolongation, or using an atypical antipsychotic and QTC prolongation. And here's the results: 15 more events per 1,000 patients, 22 more events per 1,000 patients. But as a caveat, you would see in these parentheses down below the number is that it does cross 0. So they weren't statistically significant, but that's their findings, is that you do have more QTC prolongation. Length of hospital stay, again, our fruits are covering the tree trunk, the line of null, so no difference between groups, whether you was using an antipsychotic or placebo. EPS, now this is kind of interesting. You would think that if you were using, especially a typical antipsychotic, you would find more EPS. But remember, these are randomized controlled trials, so they're eliminating probably a lot of patients that would be at higher risk for EPS symptoms. So to summarize this whole section, prophylaxis of delirium in that particular study was not effective. As far as treatment of delirium, antipsychotics not better than placebo as far as this main factors of days alive without delirium or days alive with delirium. Unfortunately, in the Gerard study, they didn't separate out those patients with hyperactive delirium. They felt that that number was too small, that 11 or 10% of patients was too small to really have a good feel for that. I would have liked to have seen that anyway, but they didn't. And antipsychotics have adverse effects, EPS and QTC prolongation. So my final area is looking at haloperidol at my campus. And we created what we call a GEMX initiative to develop a more use of an appropriate dose of haloperidol, which was defined by the Department of Geriatrics and the emergency department as 0.5 milligram IV or IM in the patient that was antipsychotic naive and over 65. The GEMX also included some other medications that I'll cover in just a moment. The point of bringing this up is that this QA project absolutely failed. And then what do you do when it fails? So we reevaluated and came up with some plans, and I'm going to show you what those are. Then I'm going to show you a haloperidol 0.5 milligram injectable presentation that I made for my ED clinician. He asked me to make it and asked me to say, why do we have to use 0.5 milligram haloperidol? So that was a good question, and I came up with this whole presentation, and I'm going to show you what that is. So as far as this GEMX, it was a geriatric medication maximum dose protocol, and we picked 5 different medications. So haloperidol, we wanted to use 0.5, ziprasidone, we wanted to use 5, lorazepam 0.5, fentanyl 25, and morphine 2 as starter doses for those patients in the ED, if they were naive to whatever type of medication we were prescribing. When we went to roll this out, we developed a written protocol, written procedure that was distributed to all the pharmacists. We sent that same procedure to all the ED providers, and they were notified in a meeting. And we gave an in-service to nursing staff about this whole protocol procedure. The initial review showed that it really didn't work. And that's what this graph is showing. And again, you don't need to have any statistics. I didn't need to perform any statistics on this. If you see here, the before group, the before group and the after group, before and after. What you want to see is the after going down, but it didn't go down. It did go down a little bit in lorazepam, but that is not a success because the other four did not decrease. And I'm going to call this just a fluke. It was just an aberration. So this procedure, this quality assurance initiative just did not work. So what do? Do you quit? Well, we could have. But what I did was for each of the GEMX medications, I retrospectively reviewed them. And if a medication above the GEMX was utilized, say 1 milligram haloperidol or 2 milligram haloperidol, I contacted the pharmacist that approved that order or verified that order and just pointed it out to them. If they did that 3 times, I gave them all 3 orders. I also developed an overall graph of the different pharmacists and how they were doing. And I published that anonymously. Originally, I wanted to have everybody's badge number, but my boss didn't think that was a good idea. So, okay. So I published it anonymously for all the pharmacists. In addition, we had our geriatricians speak with the ED directly about the use of antipsychotics. I think that was very helpful. And I also developed the presentation for the ED clinicians that I'm going to cover about using 0.5 milligram haloperidol. More currently, we're looking at a chart review of haloperidol dosing and looking at lower versus medium and higher doses and how it worked, and an epic fix. So these are all things that came as a result of our failing our QA initiative initially. So, did it work? I believe so. I'll just bring you to this bottom line. This is what I want to know. Number of doses greater than 0.5 milligram in naive patients. At baseline, we were about 2 per month. After implementation of all those changes, we were at 0. So about 100% reduction. That's what I like to see, is that for the antipsychotic naive patient, we're starting them off at 0.5 milligram. We're not saying that you can't repeat the dose or increase the dose if necessary. We're just saying use that one first. So this is the presentation I developed for my ED clinician. Why do I have to use 0.5 milligram haloperidol? I can tell you I did get resistance on several clinicians. I'm not going to go over all these general principles. Shireen did a nice job. You're going to see them on every geriatric pharmacotherapy lecture. The main takeaway point is that the older patient has increased susceptibility to adverse effects. That's just the bottom line. They're just more at risk. Start low, go slow. I know everybody in this audience has heard start low, go slow. I'm just reminding the clinicians that they should be doing this. Hopefully they've heard this as well. Start low, go slow. If we look at recommendations from 2016 by the American Psychiatric Association about the use of antipsychotics, we're only supposed to use them when agitation and psychosis symptoms are severe. We're not supposed to be using them if they can't sit still for a CT scan, which unfortunately I have seen. So we're only supposed to use them when agitation and psychosis symptoms are severe and the patients are dangerous to themselves or others. We want to try non-drug interventions first, non-pharmacology interventions first. Risk and benefits, we're supposed to be discussing those with the patient and the patient's family. And this one, start low, go slow. Treatment should be initiated at low dose and then eased up to the minimal effective dose. That's from 2016 APA. This was from a review article in 2006. And actually, I took this from the Blackboard course curriculum for the ED department, which says 0.5 to 1 milligram haloperidol intramuscularly. I also found a reference in their journal, the Annals of Emergency Medicine, which also say haloperidol 0.5 to 1 milligram. The only study I could find was a retrospective review done by Zerker, published in 2013, looking at low dose versus higher dose of haloperidol for agitation in the older patient. And about 36% received 0.5, whereas 27% received 1 milligram and 40% received greater than 1 milligram. Their findings were that whether they were on the low dose or the high dose, it didn't seem to help. So the high dose, the patients were in this hospital longer, they were agitated longer, restrained longer, they had more complications such as oversedation. Their findings were that higher than recommended doses of haloperidol were often used for delirium, and there's no evidence to suggest that the higher doses were better for those patients, and that the low dose seems to be as effective and safer than the higher doses. So that was Zerker in 2013. Now, I want to review a chart review that we did at our institution. And the basic premise of what we're looking at is when a patient receives a dose of haloperidol for an acute situation, are they receiving another antipsychotic or a benzodiazepine within 4 hours? If they're not, then we're considering that dose to be successful. So let me repeat that. So if they get a dose of haloperidol and don't need anything for 4 hours, then we're saying that that dose worked. Now, there may be some flaws to that, but I can tell you our nursing is right on top of these patients. If they're still in trouble, they're going to get another order for another medication. That's my belief. So our study, we looked at about 90 patients so far. We did exclude those patients that were on antipsychotic prior to admission or alcohol withdrawal order set. The low dose we say are 0.5 or less, medium dose between 0.5 and 1, and then high dose greater than 1 milligram. And those groups are pretty well matched. As far as the 4 hours, looking at the kinetics over 4 hours, we see that this was actually a study looking at haloperidol 2.5 milligram IV versus IM or intranasal. We don't use intranasal here at my campus, but I'm just using it for the kinetic slide. So you see that the IV greatly increased to 27 or so nanograms and then dropped off. So I did find a reference that said 5 to 15 was a therapeutic range for schizophrenia. So you can see by 4 hours, definitely any kind of haloperidol dose that's going to be gone or minimized by 4 hours. So that again justifies our use of 4 hours, I feel. As far as baseline demographics, we're not really seeing much difference between groups, maybe a little bit difference in age. As far as gender, weight, BMI, creatinine clearance, psych past medical history, if they were on benzo prior to admission, no difference. We are in the process of adding some other scores to this baseline demographics, such as delirium screen, a LACE score, which is a look at readmission risk, use early warning system, or early warning score, which is a change in their health status, and BIMS, which is a similar to MMSE. So all those we're going to add into their baseline demographics to see if there's differences between these groups. As far as our results, they didn't require any additional haloperidol dose in the low dose group versus high dose. There was no difference. As far as anything other than haloperidol, no difference between groups. Actually, in the medium and high dose, it looks like they needed more. As far as requiring additional benzodiazepine, again, no difference between groups really. In the high dose, they used a few. Length of stay was longer in the patients that received high dose. And as far as restraints utilized, the medium and high dose seem to be a little bit more. So what do we say about these results? They're really similar to what Zerker found. And we're seeing a lot of higher than recommended initial doses of haloperidol being used. No evidence to suggest that they work better at decreasing length of stay or decreasing agitation, which we described as restraint use. And low dose haloperidol appears to be as effective as the higher doses for this group. Now, we're working with Epic and developing this order for haloperidol. And it's going to pop up when the patients are greater than 65, greater than or equal to 65. It's going to default to the 0.5 milligram dose and default to IM because we feel that IM is probably a bit safer than IV. And then you're going to, the clinician is going to have to answer these questions down below. Was this patient on haloperidol or some other antipsychotic prior to this order? Yes or no. If they say no, then it just has a pop-up, well, you better use 0.5 milligram to start. The other question it's going to ask, is this patient a danger to themselves or others or active psychosis? If they say no, we're going to have an algorithm or guideline that pops up, or if it's Monday through Friday, they can consult the ACE team. So they're going to have to answer those questions, and hopefully maybe this will help to navigate away from use of haloperidol higher doses in those patients that haven't been on it prior to admission. So to summarize, medications are definitely an issue and cause admissions to the ED and falls. I feel that reducing medications, deprescribing, we do it all the time, but it's definitely challenging. There's no question about that. Prophylaxis with antipsychotics doesn't work. Treatment with antipsychotics, little evidence, or maybe doesn't work. And dosing by our clinicians, I mean, it was a long process, a long quality assurance process, but I think we can make differences in haloperidol dosing. And with that, I'm going to end. And if there's one thing that I would love for people to take away is to have an idea of some quality assurance project that something I've mentioned here sparks in you, and take that to your institution and just follow through with that. So thank you.
Thank you so much, Sean. Let's see, we have a few questions.
You do?
So for me, so can you tell me a bit more about the Epic fix you initiated after the first QA quality assurance project failed?
The haloperidol order?
Yes.
Yeah. So that it's actually hard to develop a good order that does all that you want and makes sense. And you're using sort of double negatives in there, and it just gets confusing. So you have to work with Epic and then develop something. And then I vetted it with other clinicians to see if it would work, and we made some changes after that. So it'll be interesting to see if it worked. And you notice I had it in quotes because I don't know if it's going to change doses that they use in the future. I'm hopeful, but I have also developed a magistral order that didn't work. And we had to do something different with the magistral order as far as ordering it for appetite in older patients. So that's why I put the fix in quotes. It hasn't worked yet because we haven't implemented it, and I'm not sure if it will, but I will be monitoring to see if it does work.
Great. Thank you so much. Well, since we're close on time, I wanted to thank you, John and Shireen, for providing today's webinar. As we're finished, I'll provide the CE codes for today's programs. So for the first program,